So here are my disclosures. The first question I have is regarding the CheckMate 9LA trial, which compared nivolumab plus ipilimumab with 2 cycles of chemotherapy to 4 cycles of platinum doublet chemotherapy. Which of the following groups had an overall survival benefit in this study? Only patients with squamous cell carcinoma, only patients with adenocarcinoma, only PD-L1 positive patients, or patients with any level of PD-L1 staining.
And you may be able to see that poll. You may answer this question. So
I'm not sure how I show the group results.
So do we know, Binay? So I submitted it at my end. Do we get the results? Is there a time limit before we get the results?
When I end the poll, it'll show the results. So I was going to keep it open for about 10 more seconds, and then I'll close it, and then I'll share it to you.
And responses are kept anonymous, so please feel free to pick the option that you think is best.
Okay, so I think Jack got the point across that both PD-L1 positive and PD-L1 negative patients do benefit based on the data presented at ASCO. So won't belabor this a whole lot, but like was said, this was a pretty simple clinical trial design. Yet another study comparing an immunotherapy chemotherapy combo to a platinum-based doublet with primary endpoint of overall survival. And it was significant in all groups. And like Jack, it's hard to figure out where to put this into our treatment paradigm because we're now fortunate that we have a lot of studies that show improvement versus platinum-based doublets. One of the things that I really liked about this study, though, was the pretty robust benefit seen in the PD-L1 negative population, as opposed to, the PD-L1 greater than 50%. Yes, it was a benefit, but we already know checkpoint inhibitors alone have a significant benefit in that group, so it might not be worth adding on the toxicity of ipilimumab. But yeah, the PD-L1 was mainly what I noticed. That said, I'm still not sure how I'm going to incorporate this into my clinical practice. It is listed now in NCCN. This is the the squamous cell carcinoma guidelines, and also for the adenocarcinoma guidelines is not a preferred regimen, but is an other recommended regimen, and also FDA approved in both these groups. So second question, you have a 67-year-old female in your clinic, metastatic non-small cell lung cancer. She's received carboplatin, pemetrexed, pembrolizumab. Presenting to your clinic, molecular profiling is showing a HER2 activating mutation. So which of these agents was shown to have a high response rate in this setting in patients with this alteration? Alectinib, entrectinib, docetaxel plus trastuzumab, or trastuzumab deruxtecan.
We realize this is not us taking the test. It's actually Raphael and Jack are on the spot here. So depending on how the audience answers, they are being graded.
And they're doing well.
Great, yeah.
So the correct answer is the trastuzumab deruxtecan, and this was based on the Destiny Lung 1 study design. As Jack went over very well, they presented cohort 2, which is the HER2 mutated cohort. I know there were questions earlier about how this was determined. We do take part in this trial, and it was basically any CLIA certified laboratory finding this. So it could be Foundation, could be Tempus, could be an internal test, but as long as it was HER2 mutated, there was central confirmation that it was indeed a HER2 activating mutation, and then patients were eligible to enroll. Primary endpoint here was overall response. And again, the overall response rate was very impressive, 62%. Side effects of this were similar to chemotherapy side effects. This is an antibody drug conjugate, so the idea with the antibody is to get the drug to your tumor while sparing toxicities. That said, it's not perfect, and you still get the chemotherapy-related toxicities. But I think this expands our number of targetable alterations in lung cancer. It's not FDA approved for lung cancer yet. Hopefully, in the not too distant future, it will become an option for our patients. Progression-free and overall survival, I thought were quite impressive in this group that in many cases had been previously treated. So this is one that was not directly addressed. So this is not a test of Jack and Raphael now, but this is a 59-year-old male, newly diagnosed metastatic non-small cell lung cancer. Molecular profiling shows a RET fusion. Which of the following agents would be an option for him? Osimertinib, dabrafenib trametinib, pralsetinib, or palbociclib? I feel like we should have the Jeopardy music going right now.
That's right. We really needed music.
No one wants me singing though, trust me on this one. Okay, so the majority is correct, pralsetinib. And this was actually not presented in the oral abstracts. This was a poster discussion, and this was the ARROW trial. Patients with pralsetinib, it was actually a basket trial that enrolled both RET fusion non-small cell lung cancer and other RET altered solid tumors, but the data presented here was the non-small cell population with 132 patients. And what they found were some pretty nice looking overall response rates. That response rates of about 58%, similar in both previously treated patients and in treatment naive patients. You can see on the waterfall plot there that for most patients, even if they didn't achieve a PR, they still had a response to therapy. So this is now FDA approved, it's NCCN listed, and it's just going with the continued trend that we've seen in lung cancer where we're finding smaller and smaller groups of patients that are eligible for targeted therapy. I think this is also really stressing that we need to be getting really broad mutational profiling in our patients. You know, I still see some patients that come in with just EGFR, ALK, ROS1 tested. I think we need to do more extensive testing than that, and it's becoming more and more cost effective over time as well. And then my final question, I think, is probably about the study that's gotten the most discussion and caused the most controversy on Twitter, as well as in our conference rooms. That's the ADAURA study. Compared osimertinib to placebo following surgical resection of EGFR mutation positive non-small cell lung cancer. Which of the following was shown in this study? No significant differences in outcome between osimertinib and placebo, improved disease-free survival with osimertinib, improved overall survival with osimertinib, or improved disease-free and overall survival with osimertinib.
See, somebody took the advice.
I love the music.
What do we get?
Okay. So I think this is an important point. I know we've kind of beat it to death already, but the answer is that improved disease-free survival, and there was not a demonstrated benefit in overall survival. And I think that's part of what's made this study so controversial and why Jack and I and others are trying to figure out how to incorporate this into our practice when it becomes FDA approved, which I think it will. Here's the trial design. Again, a pretty straightforward trial. Stage 1B through 3A non-small cell lung cancer. Adjuvant chemotherapy was allowed but not required. Randomized osimertinib versus placebo with a primary endpoint of disease-free survival in stage 2 and 3A patients. So here was the disease-free survival, and obviously these curves are beautiful looking and the kind of separation we love to see in trials. This was relatively immature data, reached the maturity of 33%. The overall survival data in stage 2 and 3 disease was not significantly different between these two arms. And I think that's the big hesitancy. You know, we all love how the disease-free survival curves look, but we're all struggling to figure out, you know, is disease-free survival really a valid endpoint for adjuvant treatment, or do we need to see an overall survival benefit? You know, are we helping people live longer, or are we merely prolonging their recurrence? And that's the question that I think is yet to be answered with this trial. And to be honest, if I were in this situation, I don't know what I would want. I think patients will all want adjuvant osimertinib, but I do think it's really an open question of whether we're really helping people live longer and whether the benefit in disease-free survival is worth the cost, both in terms of side effects and in terms of financial costs. So I do think when we're counseling our patients in clinic about this, we really need to be clear that yes, it's a disease-free survival benefit, but no, we don't know if it helps you live longer. It helps your scans look better for a longer time, but the overall survival is an open question. And I think it'll be interesting to see what happens after the 3-year mark as well, because this is 3 years of treatment, and then per trial, it would be stopping treatment. You know, do we see a big drop off there? Do we see lots of recurrences right at the 3-year mark? Things like that. So it'll be important to watch this data as it matures. And that's all I have. Here's some photos from Yosemite with my recent socially distanced vacation. Thank you.
Dr. Gold, what do you think will happen like after 3 years? Say we stop the osimertinib, a patient got it adjuvantly and then they relapse, then, you know, what will we use? Like then it will be stage 4 EGFR mutated. So will we have to do the stuff we do with platinum? If it relapsed within 6 months, then you don't use the osimertinib again. If it relapsed after 6 months, like what are your thoughts?
Yeah, I think if they relapse on the osimertinib, it's an easy question. You would switch to second line therapy. If they relapse after, I would probably give them another trial with osimertinib. I mean, osimertinib does not have a long half-life in the body. There's really not much of a reason to think that, you know, disease that grows off of osimertinib when it kind of responded before wouldn't respond. So I would do it with very close observation. You know, I wouldn't want to wait 3 months for my next scan. But I probably would give a trial of osimertinib. But I'm curious to hear what the other doctors have to say about this as well.
Well, I agree with that point. I think that the challenge is not what you would do if they relapse after stopping it. The question is whether, with all of that treatment, you've eradicated any of the disease at all, or whether it's just you know, holding it and making the scans look better for that period of time. But you know, you've not conferred a cure on anybody who wasn't already cured. And
sure,
I don't think we know that. But
I think most patients will want it. It will be hard to not prescribe it, at least in the community setting. I think they'll all insist on it.
No, I think that's true. I think that's part of the thing that, to me, frustrates me about the trial design. I mean, I'll say historically, we never used DFS as the endpoint for chemo-based trials that established our standards of care. ICAHO20 chemo with bevacizumab. It was felt that overall survival is the endpoint we should care about for adjuvant therapy. And to me, it's disappointing that it's just our bias and sense that newer is better that has eroded our convictions. And of course, I mean, if I were a company whose job is to sell this product, I would run trials that make this positive and get people to want to give it. But, you know, I think that hasn't answered the question of whether you've cured anybody. And that's
right. So that's more like a financial thing in the trial design. I don't think it's...
Well, I don't know. I mean, it is, if you're giving people 3 years of diarrhea and stomatitis and not curing them, and they didn't have cancer, I think it's not just a financial question.
And
sorry to